thank you very much, and it's a pleasure to meet the people that I've met so far. I have to admit, this is one of the first meetings I've attended where I've talked so much with other people prior to being involved in the organization or anything. So I just appreciate everybody's friendliness, and it's a nice atmosphere. So, and I haven't been before. So today I'm going to talk to you a little bit about aging in women with HIV infection. And one of the rubrics that I use with regard to this whole area is what's called what I call fit for purpose and fit for community. I think I'm doing this right. And my background is actually aging epidemiology, or quote unquote usual aging epidemiology, whatever that means, uninfected aging epidemiology, with a focus on the brain, so dementia epidemiology, cognition, and that kind of thing. So I entered into the HIV epidemiology space about, it's been almost 10 years ago now, when I moved to Brooklyn and joined the faculty at the State University of New York. And we've been one of the clinical research sites for the Women's Interagency HIV study since its inception, so for over 25 years. And so I'm going to share with you results from that particular study today. And what I'd like to do then is cross-pollinate from the usual aging epidemiology space to HIV aging. So about 2 years ago, I was at the National Institutes on Aging. I was invited to participate in a small group discussion related to low-cost, effective strategies for detecting cognitive impairments earlier. That's what the whole focus of the meeting was. But what I came away with as a result of listening to those talks was this idea of again, fit for purpose and fit for communities. And so that's what I apply to my research strategies within this particular area. And one of the things that I'd like to talk to you today about is what's listed here as point number 2, something that I came away with from that meeting, is that what we need to do to advance identification and characterization of populations at risk and actively recognize and use these characteristics in study design, data interpretation, and designing interventions has very much to do with understanding the communities that we're working with. Sorry, my throat is a little bit. So this is a map showing you all of the clinical research sites that accompany the Women's Interagency HIV study and also the MACs. We joined forces last year. We are now the MACS-WIHS Combined Cohort Study, or MWCCS. You can look us up at mwccs.org and learn all that you want to know and more about the cohort, as well as, if you're interested, as I'm talking, if you find a topic that's interesting, it overlaps with some research that you are doing, there's a place there for external investigators to the cohort to be able to understand more about the data that are available, ways that you can access the data. We have a distinct, operationalization of that, and you can read about how to do that on that website. So I would highly encourage you to go there. There is a webinar on this that I did for GSA, which you can access through the Gerontological Society of America if you want to do that. So we recorded that about a month ago. But anyway, back to the map. So these are the clinical research sites for both the MACs and the WIHS. The bolded locations are those that are traditional or what are called legacy WIHS sites. So you can see that we've had multiple clinical research sites across the United States, West Coast, East Coast, and those are superimposed upon, these sites are superimposed upon this map, which actually shows where the highest prevalence of HIV is in the United States. You can see that the clinical research sites are built in the environments in which we need to know the most, right? And the places that are most affected. I will just mention that there are 4 sites in the South, Atlanta, Miami, Chapel Hill, and Birmingham/Jackson, Mississippi. That's a combined site. Those are our most recent sites. They were added during the last funding cycle of the WIHS because the nature of the HIV epidemic in the South looks very much historically like what it did more at the beginning of the epidemic in what we call the North, right? And so it was deemed important to have clinical research sites in the southeastern part of the United States to be able to better understand that. And also, with this whole focus on aging, we're going to be able to use the data that have been collected historically in the WIHS for 25 years and then hopefully apply it in these other areas of the United States where we need to be able to do more in terms of prevention, intervention, et cetera. Oops. This one is tricky. Just a second. There's a little bit of a lag when you press the button. Oh, no.
Do you need to go back?
There it is.
Okay.
I got it. So this is just a schematic showing you the age distribution. Again, reflecting what I'm going to be talking about today is The cohort was initiated, both the MACs and the WIHS, at the beginning of the HIV epidemic in the United States. So that's why for the women it's been around for about 25 years, for the men around 10 years longer. As a result, we have had people in the study today who've been involved since the study's inception, but we've also had replenishments, and the reason for that is because of the early mortality that was experienced by people with HIV infection. But right now, the average age of the women in our cohort is, or the median age here is about 52. And we have approximately, let's see, I can't read that far away. We have about 8% of our women are age 60 and above. So we're only going to focus on the women today. So in terms of some demographic factors, you can see here we're primarily an African American or Black cohort of women with HIV infection. Few Latinas. Our median follow-up time, again, is going to be less than 25 years. It's 16, and that, again, is because of the high mortality that was experienced early on and then the subsequent replenishments. What's very interesting within this cohort, and the reason this is so important as a platform for studying aging, is that our women have a very high vascular risk profile. Our average BMI is obese. It's over 30. We have half of our women have hypertension. We have a good proportion of our women who are smoking, current cigarette smoking, between a third and almost a half. We have around 25% with type 2 diabetes. We have around a third with hyperlipidemia, a fair proportion with chronic kidney disease, and of course we are linked with the National Cancer Institute's SEER Registry for Cancer Outcomes, and so we do observe, cancer is a relatively rare outcome compared to vascular disease, but we do monitor cancers here as well, so 6 and 4% in the HIV positives and negatives, not only including AIDS-defining or HIV-related cancers. So vascular risk factors are very important to monitor and follow. Our lead institute for the combined cohort study now is no longer NIAID, which is the National Institute of Allergy and Infectious Disease here in the United States. It is NHLBI, which is the National Heart, Lung, and Blood Institute. That's our lead institute, which just shows you kind of the shift in terms of thinking about what it is now. We're looking at people who are aging with a chronic infection. They're maintaining their viral control. They're adherent to their meds. So now what's happening? What do we see now within this group of individuals? A lot of them report, if we have, just sit around and talking, a lot of our participants are saying that they don't really even think much about their HIV anymore. They're concerned about the things that are accompanying their obesity, right? They're concerned about their hypertension. They're concerned about their diabetes, their hyperlipidemias, and they're also concerned about the polypharmacy that comes along with it, right? So now all of a sudden they're not just taking their HIV drugs, they're taking meds for everything else, all the morbidities that they're faced with as well. So this is reflective also here in this slide. If we just look at the top 10 global causes of death, the leads are vascular in origin, right? Stroke, ischemic heart disease. You see type 2 diabetes there. You even see Alzheimer's disease and dementias here, which have a strong vascular risk profile associated with them. So to be able to understand what vascular risk is now in a group of women aging, as we said, with chronic HIV infection is very important. But not only are these top 10 causes of death important, we also need to start being considerate of geriatric syndromes, right? Because it's not just, and these are things that aren't often coded as a cause of death on a death certificate, but they are things that our women are experiencing even now at an average age of around 52. We're seeing sometimes earlier onset of some of these types of syndromes. And the Gerontological Society of America has published on their website, their list of geriatric syndromes. Maybe some of you are familiar with that. There's 9 of them. Here they're illustrated. This is actually from Thailand, I think, or from some Asian country. But majority of gerontological societies around the world hold these syndromes as being those that are key geriatric syndromes in their population. So you have things like forgetfulness and confusion, vision problems, of course, falls, osteoporosis, urinary incontinence, sleep disorders, dizziness, hearing loss, and nutritional problems. So as we went forward to think about ways to develop the protocol for the WIHS combined cohort study, continuing with some of the measures that we've always been doing, we do have additional now protocol in place to start to better monitor some of these geriatric syndromes in both the women and the men, okay? Because these are important aspects of aging and where areas in which we can intervene to either increase quality of life and or prevent further disease. So I'm going to start with frailty. So within the MACs and the WIHS, we used what's called the Fried Frailty phenotype. This is a frailty, sometimes it's called an index, Fried Frailty Index. It was developed by Linda Fried, who's now at Columbia. But it's a very simple type of index. It's comprised of 5 components, which are listed here. Impaired mobility, which is a 4-meter walk, hand grip strength, which is measured using a dynamometer, and then we actually use self-report for the 3 additional components, which include physical exhaustion, unintentional weight loss, and low physical activity. And when we assessed frailty in our sample in 2005, the women were on average age 39. We saw that in HIV-positive women, 17% were frail, and in HIV-negative women, 10% were frail. This is a very high prevalence of frailty based on this frailty phenotype. It's much higher even than in geriatric studies of usual aging, okay? So there's a lot of potential reasons why this could be the case, and I'll talk to you about that in a minute. And 10 years later, when we reinstigated, so we had one frailty assessment in 2005, and then it wasn't replicated. We reinitiated it in about 2015. And what we see is a similar prevalence of frailty for both positives and negatives. Here, however, positives have a lower prevalence than negatives, which might have something to do with medical care and consistency of care. It might also have to do with the cut points. We used different cut points actually in 2005 than 15, and we can discuss that at another time. But anyway, that was a similar prevalence at both time points. So this is then a paper after we published on the prevalence of frailty in the cohort. I went on to look at what are some of the factors that are associated with frailty. I mean, these are not old people, right? So these women are average age 39. Why are they presenting with a frailty phenotype? So we went in and we took, we were looking at a variety of different factors. It looked at HIV-related factors, infectious disease-related factors, chronic disease indicators, as well as sociodemographic factors, and we put them all in and we did this stepwise model, logistic regression model. Some of you might not like that, and some of you might think that's okay. But anyway, that's what we did. We can discuss that later too. So when we put in all these different factors, several more than that are listed then on this list, because we also looked at obesity, diabetes, hep C, co-infection, all kinds of stuff. And these are the factors that came out in terms of remaining in the model using this regression technique, such that HIV status was important and related to frailty. CD4 count was important and related to frailty, okay? So the lower, the more likely you were to be frail. The higher, the lower, sorry. Age, of course, is important with regard to frailty. So even though these women were younger, we still had a proportion of the sample that was greater than age 50. So the older you got, the more likely you were to be frail. Smoking was associated with frailty. Low income was associated with frailty. Presence of CMV co-infection was associated. Pneumonia, hypertension, a marker of liver function, FIB4, a marker of kidney function, EGFR, all associated with frailty in the way that you would expect them to. The only one that was a little bit of a interesting one was alcohol intake, which was associated, but it was actually protective at a moderate level. And why that is, I don't know. Yeah. So, but in the end, all of these things remained important. So what this basically means is that, a frailty phenotype, maybe you're walking slower, grip strength is less, physical activity low, et cetera, is accompanied by a variety of factors. Why is this important to know? It's important to know because, okay, if we're going to develop interventions or want to do something about this, look at all the things we can potentially focus on to be able to improve quality of life for people who are presenting early on with this frailty type of profile. So that's what I wanted to get across with regard to that example, if I can. We then went on to look at how frailty was associated with death. We had around 1,300 women. Again in 2005, where we followed them up for death over approximately 8 years, we compared the frailty phenotype with the VAX index. Are you familiar with the VAX? VAX is a predictor of mortality, was developed in HIV, a cohort of men. It's been gone on to be validated in usual aging, uninfected aging. It is a biomarker-based algorithm, so it only includes things that basically you measure in blood, right, which is what is listed here. So if you can't see it, it's age, CD4 count, HIV, viral load, it's hemoglobin, FIB4, EGFR, and hepatitis C. And so this would be considered more of a physiological indicator of frailty, let's say. So FREED tends to be referred to as a physical marker of frailty. This would be more of a physiological marker or index of frailty. And then we compared that to the CES-D, which is, you just heard to talk about it this morning, the Centers for Epidemiological Studies Depressive Symptom Inventory, because each of these three independently have been shown to predict death. And you can see here when we looked at this individual regression models using each index, each model showed that these indices were significantly related to mortality, okay? Higher depressive symptoms, more frailty, a higher VAX score, which would indicate a worse biological profile. In individual models, each one significant. However, if we included them all in the same model, what we found was that the depressive symptoms actually fell out. They were no longer significantly related to mortality, and it was the frailty phenotype and the VAX score that continued to predict mortality, whether it be total deaths, AIDS-related deaths, or non-AIDS-related deaths. And then we also looked at deaths occurring more within 3 years versus greater than 3 years, and saw again that it was still both the VAX and the freed frailty phenotype that were associated with death, but nothing with depression. So this did take a lot of people by surprise, because depression has been touted as such a strong predictor of death in women with HIV infection. Okay, that's frailty. Next, we're going to move on to diabetes. So there have been one of our clinical research sites at Emory, so in Atlanta, has been looking extensively at diabetes, and especially they've been looking at risk scores related to for diabetes in the cohort, and to see if the established risk scores, if they work or not. And the other thing that they've been looking at is whether or not women with diabetes are consistent in terms of adhering to guidelines. Are they adhering to the diabetes guidelines? So I'm going to share those two examples. So what the group did was they employed the American Diabetes Association and the FIN risk score. These are risk scores for diabetes in the cohort. So these are comprised of age, BMI, waist, circumference, history of hypertension, history of hyperglycemia, and family history of diabetes. There were a couple of caveats because we don't have a physical activity measure, so they had to not include that. They used a FIN risk concise model because of lacking fruit and vegetable intake. We didn't have an estimate of that either. In any case, applying these two risk scores to our population actually were not so helpful. They didn't, these are area ROC curves, and they were not as sensitive or specific as one would hope they would be in our particular population of women. So sensitivity did not differ, for example, between HIV positive and negative. Specificity was a bit better in HIV negative. So we had just kind of a amalgamation of some different results using these risk scores in the cohort. So there was greater misclassification generally observed among HIV positive women. So basically what the soundbite here is that we need better risk scores. And that's been something that's been discussed in our cohort for a long time. Do we just employ Framingham risk score for heart health? Do we just apply ASCVD, which is a little bit better maybe than Framingham because of its inclusion of race ethnicity as part of its algorithm? But how do they work? So this is just a step one in relationship to diabetes to see how accepted risk scores work or do not work within the sample. So this is something that group is continuing to follow up on. I think it's very important. The other thing that they've also been looking at is the ABCs of diabetes, for those of you who know what those are. But the proportion, this has to do with guidelines, keeping your HbA1cs down, keeping your blood pressure down, keeping your LDL level down. So A for A1C, B for blood pressure, C for cholesterol, and S for no smoking. Abiding by those four things. How do the ABCs work within our particular sample? So they took 3 cross-sectional snapshots in the cohort, and you can see here, and what I want to just highlight is that, oops, here, it's the bold one, that only about 11% of the sample actually met the ABC criteria based on 2001 data, but it was consistent whether it was 2001, 6, or 15. It was about the same proportion of individuals, of women in this case, who actually met those guidelines, who had diabetes. So this is, again, another example. It's not a risk score example, but it's an example of how another aspect of kind of caring for a chronic disease within the context of HIV, chronic HIV infection. And so a huge issue that comes out of this is that, the other thing I forgot to mention was that at the same time as not meeting the ABCs happened over a 10-year period, viral load went down precipitously, right? So the women were taking the antiretrovirals. That was falling. That was no problem. So there was a mismatch between viral control and control of an established chronic disease vascular risk factor. So I'd encourage you to get this publication if you're at all interested in the area. It was just published a couple of years ago, but obviously there needs to be better understanding of managing both a chronic infectious disease and what is typically an aging-related chronic disease. And these data speak very well to that, I think. Of course, I'm taking up way too much time. Obesity is another issue within our cohort. As I mentioned, our women are on average obese. But there's also an issue related to some of the antiretroviral therapies out there that they do cause weight gain. So this is a publication that just came out related to INSTIs, they're called, or integrase strand transfer inhibitors. They do cause weight gain, and there was another analysis done by Ms. Kirchberger, it's the bottom reference here on this slide, where she looked at women who switched to an INSTI from a non-INSTI drug. And what she found was that over an average of 2 years, in this follow-up, the women experienced, on average, 2.1 kilos of weight gain. So 5 pounds of weight gain with the INSTI switch. They also went up in terms of course, their BMI. The percent body fat went up. She had DEXA scans, as well as increased circumference, hip, waist, arm, right? Thigh circumferences increased over that time. And there was no difference by INSTI type. And I know from I'm not a clinician, but I'm talking to clinicians, they have said that people are actually, some of their patients are coming to them and asking them to be taken off the INSTIs because they are causing this weight gain. So this is an issue related to some of the antiretroviral therapies, not only the weight gain, but also an increase in the cardiovascular risk on top of what might also already be high vascular risk. So there's more research that we are able to do within the cohort related to this as well. I'm going to skip forward a little bit because I'm going to be otherwise a little bit maybe short. We have been looking a bit at obesity in Brooklyn, which is my clinical research site, and in collaboration with Chicago. We also did some work with BMI and leptin in relationship to cognition. And these are some data that were just accepted for the American Academy of Neurology meeting, which is in Toronto in a couple of months. If it is in Toronto in a couple of months, where we showed that actually a higher BMI and a higher leptin level, they're highly correlated, were predictive of worse executive function later on. And we're going on to look at other cognitive domains in relationship to that. And a greater increase in BMI is related to worse executive function 10 years later. So those are kind of interesting data when we can start looking at change, repeated measures types of data in relationship to hormones. The other thing that's interesting too, during this 10-year period from 40 to 50, these women did transition from the BMI overweight category to an obese BMI category during that transition. So again, an intervention window from 40 to 50 is when the average BMI went from overweight to obese. What do we need to do? We need to counsel women in their 40s about this, right? This would be one area where I'd say, bingo, I have something that I can target and I have data to support thinking about this issue for these women. You can only do that with a longitudinal study design in a cohort like ours. We've also done a lot of work on bone health in a DEXA sub-study within the WIHS. This is work done primarily by Dr. Anjali Sharma, who's in the Bronx at the Bronx Clinical Research Site. And we've actually seen this in Brooklyn too, but haven't published it, such that if you do body composition on women with and without HIV infection and compare the data, compare the groups, that women with HIV infection do have lower bone mineral density, and that's a pretty consistent finding. So this is based on a larger sample within the WIHS, and so there are bone health implications of HIV infection versus there is no difference. There's differences in bone, but there's no differences in adipose or fat mass, and there's no differences in lean tissue. So when you do a DEXA, right, you get a fat estimate, you get a lean tissue estimate, and you get bone mineral density estimate. And where we see the differences are in the bone. So again, something to kind of think about. I'm going to fast forward here too. And then, of course, frailty. We've got, Anjali has also been looking at falls in relationship to frailty, showing that having a frailty phenotype does increase the odds of falls, especially recurrent falls. And then lastly, Anna Rubtsova, she's at Emory as well. She's been looking at a little bit of the flip side, a positive aspect of aging, looking at successful aging, and looking at whether or not women are reporting successful aging. And despite some of these issues that I've just discussed with you, we do have a fairly high proportion of women in our cohort who are reporting successful aging. You know, they're reporting on a scale of 1 to 10. You know, we've got over 80% reporting a score of at least 7, meaning that they feel like they are aging successfully, probably due to the successful treatment of their HIV infection. There it is. So hopefully today I've given you a bit of a snapshot of aging in women with HIV infection. We've covered a lot of areas very, very quickly. Apologies for that, but I think this is an area it's a very exciting area to study. And the reason why I think this is so exciting for our cohort, especially with the longitudinal nature of it, is that we can start to identify, like I mentioned, these periods, life periods, you know, during a woman's life when certain types of interventions may be more or less important relating to certain outcomes, right? And so hopefully I've given you an idea of what some of those are. And then always to remember the health disparities aspect of it, which I didn't talk about so much. And so one of the things that we know about aging and usual aging epidemiology is we know that there's what's called midlife risk factors and there are late life risk factors. And midlife risk factors might differ from late life risk factors in relationship to late life aging outcomes, like a dementia or a cognitive impairment or an Alzheimer's disease. What's good for the heart is good for the brain in midlife, but by the time you get to age 70 or 80, it might not necessarily carry the same risk weight. So again, pointing to the very value added of having longitudinal studies like this so we can start to create some of these same pictures for HIV aging as we have for usual aging, where we kind of know the answer, but do we know the answer for this other, you know, segment of society, group of people? And again, the whole purpose of all of this is so that we can design better interventions by building life course models of risk factors and their interrelationships with each other. We can identify not only treatment targets, but we can think about appropriate interventions, whether they be pharmaceutical or whether they be lifestyle. Yes, there is a conclusion. So I would like to thank you today for listening to this. HIV aging, prevention and treatment strategies, I want to remind you, need to be fit for purpose and fit for community. And we can learn a lot from the usual aging literature. So I always encourage people to take a look at what's already been published out there, even if it's not in HIV-infected individuals, because it can help inform us now for aging and HIV. And remind you of that schematic, and thank you. And please contact me if you have any questions. 1 minute.